Good evening, everyone. My name is Pierre Dalphond, Senator from Quebec. Our esteemed colleague, Senator Martin, cannot be present with us today and has asked me to act in her stead in my capacity as Deputy Chair of this committee. Pursuant to the Order of Reference of the Senate Chamber adopted on February 26, 2026, and the Order of Reference of the House of Commons adopted on February 13, 2026, the Special Joint Committee is meeting to study the eligibility of medical assistance in dying for those whose sole underlying condition is mental illness. Today's meeting is taking place in a hybrid format pursuant to the standing orders. Members are attending in person in the room and remotely using the Zoom application. On that note, and before we begin, I would like to confirm that sound tests were performed successfully. I would ask all in-person participants to consult the guidelines written on the cards on the table. These measures are in place to help prevent audio and feedback incidents and to protect the health and safety of all participants, including interpreters. I would like to make a few comments for the benefit of witnesses and members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your microphone, and please mute yourself when you are not speaking. And for those who are attending on Zoom, at the bottom of your screen, you can select the appropriate channel for interpretation, either Floor, English, or French. For those here in the room, you can use the earpiece and select the desired channel. And we remind you that all comments should be addressed through the chair. For members here in the room, if you wish to speak, please raise your hand. For our members on Zoom, please use the raise hand function. Honourable Senators and members, this is our fourth meeting of the Special Joint Committee appointed to undertake a comprehensive review relating to the eligibility of persons whose sole underlying medical condition is a mental illness to receive medical assistance in dying. I'd like to welcome our first panel of witnesses. Before we begin, I think it was agreed, because there will be a vote at the House of Commons this evening, to reduce the length of each of our panels to enable us to gain a bit of time, 15% of time. When the bell sounds for a vote at the House, we will suspend our proceedings for minutes to go to the other floor and then come back to resume proceedings here. So, a warm welcome to our first group of witnesses.
As individual, Dr. Margaret McKinnon, Professor, Department of Psychiatry and Behavioral Neuroscience, McMaster University. Dr. Lillian Thorpe, Full Professor, Department of Community Health and Epidemiology and Department of Psychiatry, University of Saskatchewan. And representing the Canadian Association of MAID Assessors and Providers, Dr. Stephanie Green, by video conference, and Dr. Gordon Gitz, which is with us in the room. To our witnesses appearing by video conference, should any technical challenge arise, particularly in relation to interpretation, please signal it and we will work to resolve the issue. Please note that we may need to suspend during these times, as we need to ensure that all members are able to fully participate. Dr. McKinnon, Dr. Thorpe, I will invite you to each deliver a brief opening statement for 5 minutes, followed by a joint statement from Dr. Green and Dr. Gubbis. Following your remarks, our members will ask questions. So, Dr. McKinnon, the floor is yours.
Thank you. Good evening. My name is Dr. Margaret McKinnon. I'm a licensed clinical psychologist who serves as a full professor and associate chair research in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. I have secured funding for my work in the field of post-traumatic stress from the Public Health Agency of Canada, National Defence, Veterans Affairs Canada, and the Canadian Institutes of Health Research. and I'm invited nationally and internationally to serve as an expert surrounding post-traumatic stress injuries. However, I am not only an expert in the field of mental health and well-being, I am also a person with lived experience and a long-term history of depression, post-traumatic stress disorder, and suicidality. As such, I'm here this evening as a person with lived experience and would ask the committee to be respectful of their status and the status in their questioning. This is very difficult testimony to give. Finally, I'm testifying tonight as an individual, and I do not represent any organizations in the remarks that I will provide. I would like to emphasize here that while individual experiences are not generalizable, they are in fact illustrative and point to the potential consequences of a decision to adopt MAID for mental health. I have tremendous sympathy for individuals wishing to access MAID and a great empathy for those who are suffering. I'm here tonight, however, to represent those Canadians who may feel much less safe and who feel at risk with the possibility of this legislation being enacted. This is a perspective that is rarely considered. My own history with depressive symptoms and a subsequent diagnosis of major depressive disorder now spans nearly 40 years, since I was 12 years of age. I've received continuous treatment for depression since I was 24 years of age, including gold standard therapeutic approaches. In 2001, during my honeymoon, I was aboard an Air Transat plane that ran out of fuel midway over the Atlantic, during which we were prepared for the ditching of the aircraft into the ocean over a 25-minute period. Having survived this incident, I also developed PTSD. I am very fortunate to be part of the system, and over the years have received access to both standard and leading-edge mental health treatments. And yet, despite this access and the ongoing support of family and very close friends, I have suffered a years-long period where I wished to die, had a fully fledged suicide plan and access to means, and lived with a hopelessness that meant I saw my life as not worth living. Critically, I would have been an ideal candidate for MAID for mental health at the time, with a long-term history of mental health difficulties that I saw both as irremediable and associated with grievous suffering, despite continuous treatment. In fact, I believe if the proposed legislation allowing MAID for mental health conditions had existed at the time, I would not be here to testify tonight. Instead, I believe I would have availed myself of this option at a time when I was also a much-loved family member and friend and functioning at the level of an accomplished faculty member and clinician at a major Canadian university and hospital. I would have chosen this option to die and would not be here. Instead, I am now in a period of primarily sustained recovery, despite my previous persistent wish to die. In the intervening years, I've experienced periods of both relapse and recovery with treatment ongoing. A year ago, I found many of these thoughts of suicide and the desire to die returning. Despite being a mental health professional, it was shocking to me how quickly these thoughts returned, how strongly I believed I'd like to access MAID, and how irrevocable these feelings felt. While I recognize I may have needed to wait for MAID access under these conditions, the future that I envisioned for myself at that time was one that clearly included MAID. In sharing this experience, I hope that I'm illustrating to the committee the lack of safety that some Canadians feel in light of this legislation. To me, this feels as an option that, should I become ill for a long enough period of time, or my life circumstances change substantially enough, I believe that I would make an attempt to access this, despite clearly recognizing, when well, that there is hope for recovery as I'm experiencing now. I am very fortunate to be a person with good access to mental health care, financial means, and extensive social support. Yet I feel at great risk in this situation. Moreover, as has been illustrated repeatedly in the committee's deliberations, it's a fallacy to believe that all Canadians have equal access to treatment for mental health conditions. In the case of PTSD and depression, national and international guidelines recommend what are essentially first, second, and third line treatments. As incidents like Tumbler Ridge and its aftermath illustrate, access to first-line mental health care for rural community members, for example, is less available than in other regions of the country, let alone for second and third-line treatments. I would therefore appeal to the committee on two fronts. The first, to consider those Canadians who, like me, will feel at risk and unsafe should this legislation be enacted. The second is to acknowledge that not all Canadians will have equal access to all recommended gold standard treatments prior to undergoing MAID in a country marked by economic, geographic, and cultural inequities that continue to persist despite marked efforts to address such wrongs. Thank you.
So now Dr. Thorpe.
Thank you so much for that wonderful presentation. And it is what I've heard from others as well. And thank you for your courage and speaking. So and thank you for inviting me to the committee. I'm happy to give feedback on the eligibility for medical assistance in dying for people whose sole condition is mental illness or disorder. And I work as a geriatric psychiatrist whose interest has focused on aging in people with intellectual disabilities, but also other disability communities and aging communities. I do a lot of the complex capacity assessments in our health authority. And I was asked to become involved in the planning process back in 2015 prior to legalization, and I've remained provincially involved now that it has become a provincial program in Saskatchewan. I have worked with learners at many levels, and I've had involvement with a variety of research processes. We've done projects looking at the large number of medications provided elderly patients in the last 6 months of their lives, with results consistent with other data showing that we often provide treatments that are not beneficial at the end of life, and that be making the end of life more difficult. I've had learners explore my data in exploring unmet needs in people applying for medical assistance in dying, as we very much want to avoid having people end their lives because they have not had appropriate access to resources. We have also approached looking at dying, the background of people who've approached medical assistance in dying applied, and found that these were largely people with high income, high educated backgrounds. One of our other projects was with people who had spinal cord injuries a number of years ago, and how they felt we should deal with this when people with new injuries approach us for this. And we got lots of feedback letting us know that they feel that we need to be very cautious and involve people who've had personal experience in giving some feedback before this proceeds. So I'm talking about my clinical experiences, and I'm not an expert on the legal interpretations that others have presented on. So this has been very clinically and ethically challenging to all of us involved, directly or indirectly. We initially assessed people with severe and untreatable cancers almost completely, who already had involvement with the cancer clinic and palliative care. They were people with high education, high socioeconomic status that were available, aware that MAID was available. And there was a lot of stigma about talking about this, which meant that people were often not accessing full resources because they didn't tell people they were planning to die. So since 2021, we've had still largely people with terminal illnesses, but more chronic conditions starting out as well, track 2s. And these have been much more challenging, with chronic mental disorders, social isolation, demoralization, and often a lack of full understanding of their full resources. I'll give you an example. I saw a homeless patient in a shelter that I had previously met in hospital, and he had ended up with no medical care. He did not have his insulin. He did not have his medications for severe neuropathic pain, and he didn't even know there was a nurse practitioner who could get him involved with this and get his medications. And we, of course, did not approve him, but we did get him connected with the appropriate resources. And it's certainly sad that it sometimes needs a MAID request to get hooked up with resources. And my primary goal with track 2 patients, and these are the ones that are most similar to the patients we're talking about now, has always been to improve the quality of life so that they don't need to die. And this is very intensive and summers of work. And so this is a very important thing, how we set up supports for us doing these assessments. I don't think the rest of the country has this, so it's very important. So in talking about MAID with sole mental disorders, there is even more challenge than just track 2. They are often convinced nothing will ever get them better. And paradoxically, some of our patients tell us that knowing they could have an access to a peaceful death, as long as they become engaged with appropriate treatments, might well get them to engage with treatment long enough to stabilize. And we're seeing this with track 2, that they really want to die, but they are told they will only get this if they have had some appropriate engagement. And so in mental disorders, we really have a hard time knowing how this is going to go. It often takes years to fully stabilize, and we can't really predict this. And it is particularly difficult for young people who have many years left to live. They may be more impulsive and might live long enough to see improvements in many of the interventions.
Thank you.
So, and I would just say the same thing that I was talking to a woman very similarly who also told me in her high 30s that if MAID had been available in her 20s, she'd long been dead. Now,
Thank
I
you
know
very
I'm
much.
close to my
Finally,
end.
you have to wrap up. Sorry.
All right. So last thing I'll just mention that there are other people who've tried everything for many, many, many years and older people. And for them, I would still hope that we would have some way of allowing them to have a peaceful death. But this will be the minority.
Thank you very much, and sorry, but I have to cut you because the time is important for everybody. So will that be Dr. Gubbins that will speak? Dr. Green? Okay.
It's Dr. Green who'll speak.
Dr. Green, we're listening to you. You have the floor.
Yeah, I too appreciate both the previous speakers. Thank you. My name is Dr. Stephanie Green. I'm a family physician with over 30 years of clinical experience, and I've been a MAID practitioner in British Columbia since June of 2016. I'm here today with Dr. Gordon Gubbins, a neurologist based in Nova Scotia, who has also been a MAID practitioner since law allowed. We have both been deeply involved in MAID training, oversight, teaching, research, and curriculum and guideline development at the local, national, and international levels. We're here today as representatives of the Canadian Association of MAID Assessors and Providers, a national professional organization I co-founded and have helped lead for nearly a decade. CAMAP is the community of diverse professionals involved in administering and delivering assisted dying across Canada. It supports MAID professionals in their work, educates the healthcare community about MAID, and provides leadership on determining standards and guidelines of practice within the laws of the country, all of which supports our patients, their families, and hopefully one another. I'd like to emphasize that CAMAP does not advocate for change in law. We have no role in determining what the laws of this country do or do not permit. Rather, we recognize that that is the role of Parliament. We empathize with the challenging task facing this committee, and we are pleased to be able to offer insights from our 10 years of experience. One of CAMAP's contributions to MAID practice is the Canadian MAID curriculum. This project began when CAMAP was approached by parliamentarians to lead this initiative, and it was funded through a grant obtained from Health Canada. A peer-reviewed publication describing the extensive development framework and the robust editorial review process that was undertaken has been submitted to you for your information. The result is a rigorously developed, comprehensive, bilingual national program, fully accredited by the Royal College of Physicians and Surgeons of Canada, the College of Family Physicians of Canada, and the Canadian Nursing Association. The accreditation process of these organizations is the mechanism through which continuing professional education is determined to have appropriate quality for doctors and nurses. The curriculum requires a significant healthcare background in order to understand the content. Furthermore, early modules are a foundation for later, more specialized content. This explains why, despite being asked to supply this committee with a copy of the module on MAID and mental disorders, we sent you a package outlining the entire curriculum so that you can view it in its context. This committee's mandate is to undertake a comprehensive review relating to the eligibility of persons whose sole underlying medical condition is a mental illness to receive MAID. Part of that assessment has been to try to determine clinician and system readiness. We can attest to clinical readiness. Medical and nursing practitioners in this country are well-trained and competent in assessing a patient's decision-making capacity, the voluntariness of their requests, and suicidality. These skills are, in fact, utilized every day and with every patient encounter. Professionals who have taken the Canadian MAID curriculum have further expanded and deepened their knowledge and skill set. For the past 10 years, MAID practitioners have assessed patients with comorbid mental illness. We already have a decade of experience assessing if the mental state of an individual interferes with their decision-making capacity, if the request is truly voluntary, or if they're suicidal. When a 63-year-old woman with pancreatic cancer came to see me a few years ago for an assessment of eligibility for MAID, we also needed to discuss her lifelong bipolar disorder required, the successful and the failed treatments through the years, and yes, her history of suicidal ideation. The law requires that I form a medical opinion as to whether her request for MAID was being influenced by her mental disorder, whether it was voluntary, and whether or not she was suicidal. I used my training as a family physician, the extra training from CAMAP, and was grateful for the input of her treating psychiatrist. This work is doable. And yes, some patients may be even more complex. But as my daughter recently reminded me, some things are hard, but you can still do them. Further readiness is evidenced by CAMAP's release of national guidance documents on assessing capacity, assessing incurability, and the approach to people with complex chronic conditions. Nationally developed model practice standard for MAID has contributed to the understanding of regulatory standards, and the Canadian Psychiatric Association has just released further guidance on evaluating eligibility criterion in persons with mental disorders and on the management of suicide risk. All of this to say, the clinicians who are willing and interested in doing this work are ready. Dr. Gubitz is in the room with you and will be happy to take the majority of your questions. Thank you for your attention.
Thank you very much. Right on time. So now we will start by the question from members of the committee. So we'll start by MPs. Each will have 4 minutes, 15 seconds, and we'll start by Mr. Cooper.
Thank you, Mr. Chair. I'll direct my questions to the CAMAP witnesses. Section 4 of Module 7 on MAID and mental illness, entitled Specific Mental Disorders and MAID Assessments, features, quote, the most common disorders associated with MAID requests. Common disorders featured in this section include major depression, personality disorders, trauma-related disorders such as PTSD, substance use disorder, and autism spectrum disorder. So to be clear, anyone with these disorders and others, including autism spectrum disorder or substance use disorder, or someone with PTSD, could qualify for MAID in the context of having a sole underlying mental health disorder, correct?
Yes, that's correct.
Okay, thank you for that. Now, CAMAP is, and just to be clear, could be anything in the DSM-5.
As long as it meets all of the criteria related to a grievous and irremediable medical condition.
Right, so that would include things like anxiety, schizophrenia, etc., correct?
It's entirely possible.
Okay. CAMAP is involved in developing standards and guidelines, in MAID practice and in developing curriculum and educating MAID practitioners. Is that fair?
We prepare guidance documents.
Yeah, okay. And I take it as a given you would agree that training and standard setting require an objective, non-ideological, evidence-based approach?
Correct.
Okay. Yet several recent past CAMAP board of directors members, as well as the member of the curriculum review committee, sit on Dying with Dignity Canada's Clinical Advisory Council. Do I have that right?
I would need to know the details. I'm not familiar with specific members.
Well, I have a tough time believing
I'm happy to speak to that.
The details.
Sorry, I could speak to that as I'm one of those members.
Just one second there.
Juste sensibiliser mon collègue Cooper.
When he interrupts witnesses, unfortunately that cuts off interpretation, and we'd like sentences to be finished. The interpreter can interpret and we can hear. This isn't a dialogue. We're here at a committee. We have to respect the two official languages. Thank you.
The questions so that the witness completes the answers, that translation can be done. Thank you.
Well, your co-witness, Dr. Green, sits on the Dying with Dignity Committee, and yet she served as president of CAMAP, and she was involved in the development of the curriculum. Do I have that right?
Dr. Green will answer that question.
Thank you. My apologies for cutting you off earlier. I appreciate the question. In the very early days of MAID, there were very few clinicians in this country who were willing to do this work. Those of us who developed expertise in this work were asked to sit on advisory committees for a number of organizations in a number of countries. We sit in that capacity.
It was yes or no?
It's his time.
It's my time.
We are not there to
it's my time,
advise because
she's
of
not going to run out
ideology.
the clock.
Sorry, just make maybe shorter answers because time is running. Thank you, Dr. Green.
Right. It's not an ideological appointment. It's an advisory
I asked
capacity
if
with someone with subject matter
and
experience.
you answered in the affirmative you were. And when I look at Dying with Dignity Canada's Clinicians Advisory Council. There's Dr. Valerie Cooper, who was involved in the curriculum update. Tanya Dawes involved in the curriculum update. You were involved in the curriculum update. Erica Maynard was involved in the curriculum update. Osman Sheikh was involved in the curriculum update. Kanya Troughton was also involved, and she also served as the past president of CAMAP. So how do you square members of CAMAP's board of directors, an individual directly involved in the development of CAMAP's MAID curriculum, simultaneously serving the leading pro-MAID expansionist activist organization, Dying with Dignity? How do you square that?
Dr. Green?
25 seconds.
Yes, we're not serving them. We are there as subject matter experts on the topic.
Well, I would say CAMAP's claim of being objective and evidence-based are not credible given the direct ties between CAMAP and the leading pro-MAID expansionist activist organization, Dying with Dignity Canada. You have no credibility.
Thank you, Mr.
I would
Cooper,
respectfully
for,
disagree.
Your remarks. So now we go to Mr. Maloney.
Thank
for
you.
4 minutes, 15 seconds.
Thank you, Mr. Chair. I want to thank all the witnesses for joining us this evening. I've encountered all of you before, I believe, in previous iterations of this committee. Dr. McKinnon, I want to start with you. You're here as somebody with lived experience as opposed to somebody who's appearing as a medical psychologist. Is that correct?
That's correct, yeah.
Okay. And just so I'm clear, if I understood your evidence correctly, you are anti-expansion. You do not believe that the law should include people to apply for MAID whose sole underlying medical condition is mental illness?
My belief is that we are not prepared in this country for that to occur, primarily due to the inequities in the allocation of mental health resources and mental health treatments.
Great.
First and second, third line treatments need to be available to everyone.
Thank you for that. And that is based on your own lived experience, having been through a period of your life where you said you would have sought access to MAID, correct?
Yes, I would have. Yeah.
Okay. So now, Dr. Thorpe, I wasn't clear with your evidence either. Are you pro-expansion or anti-expansion?
I am a middle-of-the-road person who feels that it should be occasionally available in rare circumstances, but not without considerable thought and planning as how we're going to do this safely on a clinical basis. How are we going to constitute the groups of people who look at this?
Thank you, Doctor. That sort of answers my question. I'll put you in the anti-category because that gets to the crux of the issue, in my opinion. If we can't arrive at a consensus, then I'm not sure how, as legislators, we can recommend that we proceed. So I'm going to now move over to Dr. Green and Dr. Gubitz. Dr. Green, you were unequivocal that we are clinically ready. You said you're not here to advise on how legislators should proceed, but then you went on to say we're clinically ready, you have confidence in our system. How can you say that after having listened to Dr. McKinnon's testimony tonight?
I'm actually very much in agreement with both of the previous speakers. I think Dr. Thorpe just expressed very nicely that this should be available in very rare circumstances and only after careful evaluation. I think that's very consistent with what I've said and what CAMAP believes. I would tell you that clinicians are ready, like we were ready in 2016, like we were ready in 2021.
Okay,
like
Doctor, I'm
ready.
going to interrupt you because I've heard your evidence the last two times as well. The problem is we can't pass a law that's as equivocal as you're putting forward. We have to pass a law that it's either allowed or not, and then that puts it in the hands of practitioners, and we have to trust the system. We have had numerous practitioners appear before this committee this time and the last two times who said we are not clinically ready, and the system is not prepared for multiple reasons, including the fact that we don't have resources. What do you say to that, and how do you answer that question after hearing from Dr. McKinnon?
I think that those clinicians are not ready, and so they should not be involved in the work. The few people who are ready could be involved in the work.
With all due respect, you know as well as I do, there will be doctors who are involved in the process that may not have the same level of ethical standards and professional approach to this issue as you do. So how can I, in all good conscience, when I have doctor after doctor and professional after professional coming here telling me we're not ready for that reason? And in fact, if I'm not mistaken, you have said in the past that lack of consensus is not a reason to proceed. In my respectful opinion, that is the reason not to proceed.
I would say this committee is not going to reach consensus, and I expect that they will proceed. I expect the Supreme Court doesn't reach consensus, and they will proceed. I expect you can make a difficult decision.
Yeah, well, we're in the business of making difficult decisions, but these decisions are irreversible. So you're asking us, you're telling us that we have a system that is ironclad and ready to go
10 seconds.
and passing a law that allows people to end their life. And after hearing from Dr. McKinnon, I just don't know how you can say that with any degree of confidence whatsoever, Doctor.
Is there a question there?
Question.
Thank you.
Thank you. So the next questions will be from Madame de Bellefeuille. Vous avez 4 minutes, 15 secondes.
Merci, Monsieur le Président.
You have 4 minutes, 15 seconds. Thank you, Chair, and thank you to the interpreters who are doing remarkable work interpreting us this evening. Dr. Gubitz, until March 31st, I was a social worker, a member of my professional body. And I believe in medical assistance in dying, who's defended it. However, the whole matter of adding mental illness to the equation raises a number of problems for me. And it doesn't seem like we have a clinical consensus on the way to determine whether a mental disorder is irremediable. The clinical criteria we use to know whether or not a person should have a right to MAID. Could you explain how do you define whether a mental disorder is irremediable or not?
Thank you for the question. Mr. Chair, the definition of irremediability has been discussed at this committee for the last 3 sessions by experts in psychiatric disease as well as by the legal scholars, etc. Practically speaking, from the point of view of the Canadian Association of MAID Assessors and Providers, we were required, as requested by Parliament, to come up with training that would allow the average physician and or nurse practitioner to be engaged in the sort of clinical practice that would allow them over time and with extensive consultation with the patient and with those who support them and with those who treat them and with other collaborative sort of approaches to really understand the fullness of that person's experience. In terms of irremediability, that's very difficult to assess in a day, a week, a month. Obviously, we're looking for many probable years of treatment with all of the available technologies and medicines and resources that are available with the support of experts in that particular illness, disease, or disability, because we know that not every clinician who is involved in MAID work will have the experience to deal with every patient that sits in front of them.
On sait qu'au Québec, l'aide médicale à mourir a été...
In Quebec, medical assistance in dying is far more advanced in Quebec, where they've shown leadership. There's even been requests for, there's been adoption of advanced requests. So Quebec is moving forward. Nonetheless, there are fears about broadening MAID to mental illness. In its 2023 report, it closed the door to this because there wasn't a clear clinical consensus, and that professionals weren't actually in a position to deal with this matter. Do you have an opinion on the work that has been done in Quebec on this front?
As a representative for the Canadian Association, I don't have a specific opinion about what's gone on in Quebec, but can speak more nationally. Quebec, of course, is a member of the Canadian Association of MAID Assessors and Providers. Many members from Quebec are there and are involved with our work. I would think what you're speaking about right now is clinical readiness. And so how do we determine clinical readiness? We have the Canadian MAID curriculum, which you've been provided with a copy as well as the paper about the development of the process. We also have guidance documents produced by CAMAP to talk about very specific things that Dr. Green mentioned in her opening remarks. We have an online assessor forum through the CAMAP group, an online provider forum, and those allow in-time conversations to be held between clinicians to talk about difficult cases. And these are all protected in a firewall sort of thing. We have regular difficult case scenario conferences that CAMAP members are invited to attend. They come, they present a case, they hear experts from across the country talk about that. As Dr. Green mentioned, we have a national KMAP meeting. It's happening this Thursday, Friday, and Saturday in Montreal, and many of the things that are being discussed around this table are being presented as plenary sessions with lots of complex discussion. Supportive documents include the Canadian Psychiatry Association document, which deals with these things, as well as the model practice standard and the advice of the professionals.
Thank you. Thank you, Dr. Gubitz.
So we turn now to questioning by the senators, and I would note that since Senator Delfond is not going to ask a question, we can give them each their 3 minutes. So we start with Senator Moody for 3 minutes.
Thank you, Mr. Chair. Through you, my question is for Dr. Gubitz. Dr. Gubitz, you have encountered individuals who have made suicide attempts in the past, and you've encountered individuals that say that if they're not found eligible for MAID, they will complete suicidal attempt. And you've encountered individuals who have suicidal thinking at the time of the request. Is this so? Is suicidality something that arises in MAID practice, even though persons with mental illness as their sole underlying cause are excluded right now?
Thank you for the question. Mr. Chair, as clinicians, we encounter patients who have suicidal thoughts, actions, and ideations in every aspect of our clinic, who's recently been diagnosed with ALS.
Thank you. And I have another question that really I'm finding it very interesting to listen to the discussion. In my experience, when there is not an expertise available in a particular town, province, or location in this country, physicians don't get up and just do and provide that service. If that expertise is not available, unfortunately, that service is not available. Is it your expectation that there will be physicians who suddenly decide they're going to provide MAID, even without the expertise that is needed?
So according to everything that we understand from how assessments are to be done and the regulations around that, it's not possible to complete an entire MAID assessment without the opinion of somebody who has expertise in the condition. If I assess a patient who has a high spinal cord injury and I have no expertise in that area, I am compelled to speak to a colleague or make a referral to somebody who has that expertise. I could give an example if you wish.
Could you? Thank you.
I followed a patient, a young woman with trigeminal neuralgia, a very painful facial disorder. She did not tolerate any of the medications. She had 2 separate surgeries to require this to happen. She came to me asking for MAID after she'd lost 40 pounds and was no longer able to eat, except very painfully. I referred her back to the surgeons who did a cross-country assessment. They had a video conference call about this person in particular to determine whether or not there was anything else that could be done for her. We sent her to pain specialists who were not able to add anything else, and she went on to have a medically assisted death at a weight of 70 pounds.
Thank you, Mr. Chair. I'm assuming I have no more time.
Thank you.
Okay, thank you. Senator Osler for 3 minutes.
My question is for Dr. Gubitz. We've been told that the justification for the exclusion is that mental disorders and physical disorders are different. And the way they are different is that mental disorders do not have a predictable course, but physical disorders do. Can you give some examples of neurological conditions that do not have a predictable course? Second part, when you have to determine if a person's neurological condition is a grievous and irremediable medical condition and the prognosis is not certain, how do you come to a determination if the person's condition fulfills this criteria?
So, Mr. Chair, thank you very much for the questions. In terms of specific neurological disorders, one might think about certain types of movement disorders, Parkinson's disease, etc., which could have a variable presentation lasting from several years to dozens of years, in which case they have to go through life with those symptoms and try and manage as best they can. Some of the neurodegenerative problems, certain of the less common dementias may have presentations like that. In terms of people, the second question, for people who we have not yet determined them to have a grievous and irremediable medical condition, in most serious neurological disorders, the answer is time. Because in serious neurological disorders, things get worse over time. The example, once again, being something like motor neuron disease or ALS, starting off with a twitch in a foot and ending up in a wheelchair two years later, fed by a tube.
Time for a third question. We've also heard testimony that the curriculum, the CAMUP curriculum, has not dealt appropriately with ableism embedded in our society. Can you respond to that?
So ableism is mentioned in several different components of the curriculum. The most notable would be in topic 4, which assesses capacity and vulnerability. There are specific top bits within the curriculum that deal with ableism. I'll just finish with some advice that we provide to assessors and providers. The first is that they acknowledge that persons with disability requesting MAID have experienced trauma and that the medical system and society at large may have contributed to this. So an acknowledgement that this exists for a person with a disability. The second is avoiding presumptions about their experience and making sure that they're engaged in specific and detailed conversations within the context that the patient will allow us to be involved. Sometimes that involves collaboration with other health professionals, social workers, caseworkers, people they've been involved with. And then the third and perhaps the most important part is to try and distinguish between the suffering caused by the medical illness, disease, or disability and the suffering that's caused by injustice, discrimination, stigma, and exclusion. And those are hard to do, and they can be interwoven, and there is no perfect answer to this. I will agree with that.
Thank you,
but
Dr. Gubitz. Senator Wells for 3 minutes.
Thank you. My question is to Dr. Gubitz. We've heard a lot about consensus. Can you tell me whether, from your perspective, there was consensus when Track 1 came in?
I think with Track 1, casting my eye back, because the parameters were so small, grievous, irremediable, and with no mention of Track 2 at that time, when MAID practice originally began, Dr. Green can speak to this, and I believe Dr. Thorpe as well, we were basically, pardon the expression, but reaching for the low-hanging fruit. These were people who are at the very end of their lives, who are suffering tremendously, mostly from cancer, end-stage heart failure, end-stage other organ failure, who clearly met all of the criteria.
I'm going to switch to curriculum. Can you speak a little bit about the consultation that's been done to design the curriculum and of now what you've heard from clinicians on how they're using the guidance?
Sure. So the curriculum, there is a document that was submitted, I believe, through the clerk called the Development of a Canadian Medical Assistance Design Curriculum for Healthcare Providers. So it exists as a document, and it provides all of the detailed background. Those of us involved in medical education are not educational experts, so we relied on Queen's University, their Department of Higher Education, to put us through an entire process that was very evidence-based and adopted the highest of educational standards. The feedback that we've had from the curriculum thus far, well over 95% of the people who attended the curriculum felt that it was beneficial and that it would have improved their MAID practice, and a good proportion of those who had not provided MAID were interested in beginning to incorporate MAID into their careers.
So with the recent guidance and materials that have been developed, can you talk a little bit about what were the particular gaps that were trying to be addressed?
Sorry, gaps with respect to?
From what you've heard, so moving to, sort of sole underlying condition of mental illness in the new guidance and the materials, what was missing from the knowledge providers had to what you've now been able to provide them?
So I think that the development of the curriculum allowed folks to go through the curriculum from the beginning to learn how to do an assessment, et cetera, through vulnerability and capacity, complex cases, all of those other modules to get to Module 7. So very few people would have taken the 7th module as a standalone because it presumed a significant amount of background knowledge of all of these issues that have come before. I think people who have taken the curriculum Module 7 are better prepared than the average person to deal with the question about mental health as a sole underlying condition, and we would encourage more people to partake of the curriculum as it goes forward. We think it's an excellent product.
How many hours?
You have about 10 seconds.
Okay, how many hours would you say the totality of that curriculum is?
27 hours for the entire curriculum.
Thank you.
We now move to the second round with members of MPs. So, Mr. Patzer, for 2 minutes, 33 seconds.
All right, 33 seconds as well. Okay, thank you very much. Mrs. McKinnon, as a mental health professional and a person with lived experience, and as an internationally recognized expert in traumatic stress, can you distinguish between suicidality and the desire to die? Oh, she's on mute.
My apologies. No, I cannot. When I was experiencing suicidality in relation to MAID, I did not distinguish between the desire to die and that's a suicidal ideation or suicidal intent. I just cannot make that distinction as a person with lived experience. As a professional, I know for things like not criminally responsible, we have reliable and valid scales to assess that. And I don't think that should be holding this decision to a lower standard of evidence.
You said that if MAID for mental health had been available during a period of severe illness, you believe you may not be here today. So in your view, what does that say about the danger of treating a person's desire to die who has a mental illness as irremediable?
I think that it's very difficult to conclude that someone has no hope for recovery. One of the hallmarks, I would say this certainly as a person with lived experience, of a mental health condition is the belief that this will never end. I've certainly felt that way during a time of prolonged depression. So that's part and parcel of the disease and the condition. But, to make that judgment that there is no hope, I think is really difficult. And I don't envy healthcare professionals that would have to make that decision. I think it's going to be very difficult for them should this go through.
Thank you for that. And just lastly here, you said you had good mental health care, financial means, social support, and professional knowledge, yet you still felt at risk. If someone with those supports could feel unsafe under a current system, what does that mean for Canadians who are poor, who are isolated, who live in rural, remote communities, who are disabled or unable to access specialized care or the first, second, third line treatments as you referred to either?
This troubles me deeply because if we look at international and national guidelines, we have recommendations for first, second, and third line therapies. Those are both pharmacological treatments and non-pharmacological treatments. Many Canadians, as we know, have difficulty accessing those first line treatments. To have access to, treatments that have less evidence yet have shown effectiveness for some individuals, I just don't see that happening in our country. I'm sure there are statistics that would support that as well.
Interpréter, appel au règlement, l'interprète, il n'appelle pas assez fort la témoin, donc l'interprète est incapable d'interpréter.
The interpreter has said that the speaker isn't speaking loud enough for the interpreter to interpret.
Repeat it briefly.
Would you like me to repeat my answer?
Yes, the last part of your answer.
Certainly. So, if we look at national and international guidelines surrounding the treatment of mental health conditions, there are often recommendations, if not in all of these guidelines, for first, second, and third line therapies. Those are both pharmacological treatments and psychological treatments. The majority of Canadians, as we know, may have difficulty accessing a first line therapy for a mental health condition, let alone those second and third line therapies. Where these inequities exist in Canada, it just, that really troubles me that some people will receive MAID for mental health, having received access to all three, particularly if they have financial means. For those who do not, so if we think, for example, in Nunavut and individuals living in Pang, Nunavut, for example, who there's almost a complete absence of mental health and well-being resources.
Thank you.
Will they have access? Thank you.
Thank you very much. Maintenant, nous allons passer Madame Koutrakis.
I'll now give the floor to Madame Koutrakis. You have the floor. Thank you, Chair.
To Dr. Green and Dr. Gubitz. Do you think systems of MAID oversight and quality assurance are adequate and consistent across Canada?
So the systems of oversight across Canada are provincially and territorially regulated, and so will vary from province to province and jurisdiction to jurisdiction. There are many groups that have retrospective chart review and audit, like the Ontario system. There are systems where I'm from in Nova Scotia where we have both a prospective and a retrospective review of cases in an arbitrary sort of way. So it's difficult to speak to the totality of the Canadian experience. I think each province and territory is obligated to ensure that regulatory standards are upheld to the level that they can be. Very important.
Is there something that you wanted to add, Dr. Green or Dr. Thorpe?
Yes, I would just say that, of course, there are federal legislation requirements for oversight that just spoke to territorial oversight mechanisms. There are also professional standards that clinicians need to follow that are upheld in every region of the country as well. And there's often local facility or regional guidelines as well. So there's quite a few layers of oversight that are there. And we do know that at least 90% of all cases are individually reviewed in the country according to Health Canada data.
Dr. Thorpe?
Sorry, I don't have anything to add to that, but it does certainly vary across the country.
Okay, great. My next question is, if consensus is not required in medicine, and we've heard this several times, what threshold of clinical disagreement would, in your view, justify delay implementation? It sounds to me that, across the provinces and territories, it varies. So what do we need to be mindful of to make sure that the threshold of clinical disagreement would justify delaying implementation? Dr. Thorpe?
30 seconds left.
Yeah, that's a tough question. I don't have a good answer to that. I'm going to pass that to Gord or Steve or Nat. Dr. Green.
I would say quickly that clinical medicine always involves disagreements or differing opinions depending upon how the evidence is acquired and how the patient is examined and the information they provide. One of the reasons that we have two assessments for each patient is to ensure that we have a consensus of opinion around the individual case itself.
Thank you. Now, Madame de Bellefeuille, vous avez le micro.
Madame de Bellefeuille, please. Thank you. Dr. Gubitz, in your practice, and you were involved in developing practice, someone who has depression and who has suicidal ideation, should such a person be eligible for MAID?
I would answer briefly no. If the person is actively suicidal, assessments for MAID are off the table. We need to ensure that the person has been referred to the appropriate mental health services. We occasionally encounter a circumstance as well where we find somebody ineligible and they say, well, I'm just going to go and kill myself then. And my response to that is to telephone the police and do a wellness check on them and to ensure that they are going to get the care that they require, in addition to speaking to the care providers who have referred them to me.
Quelqu'un qui fait une dépression et qui fait une tentative
Someone experiencing depression and who makes a suicide attempt and ends up at the hospital and then asks for MAID, would such a person be eligible?
Well, once again, Mr. Chair, I think that the clinical scenario would have to allow for some degree of stability over time to ensure that they are outside of this crisis, whatever resulted in the suicidal ideation. I think referring to the Canadian Psychiatric Association document around how clinicians go about assessing patients for suicidality it would be a reasonable standard for across the entire country. It's very well laid out.
que quelqu'un qui a des idées suicidaires.
So someone who has suicidal ideation wouldn't be able to access MAID easily because clinically it would have to be proven that all clinical attempts were made to support them, to treat them, and to get them through their time of crisis.
And once again, that depends upon the individual circumstances of that patient. We have encountered people who have, I'm terribly sorry.
We now go to Senator Moody for 1 minute and 42 seconds.
Thank you, Mr. Chair. I just want to ask Drs. Green and Gubitz a question because I'd really hate for the general public who are listening today, this evening, to this discussion, to come away with the idea that physicians in Canada are reckless, uncontrolled, that they practice procedures and medicine that they're untrained for, essentially that they're unethical. So the question is this: in your opinion, do practitioners who are not properly trained, to not adhere to professional standards, will they get involved in complex MAID cases? And the second part of the question is it not the case that physicians are under a professional obligation to only practice within their scope of practice, i.e., within their professional competencies?
So thank you for the question.
And is there not a process by which people can complain if any physician is found to be acting outside their scope of practice?
Dr.
Thank
Gubitz,
you.
30 seconds. Say back.
Right. So, Mr. Chair, thank you. Physicians are obligated to practice to their scope of practice and their standards according to their provincial college or territorial colleges. Medical assistance in dying is no different. Unethical people practice across the sphere of medicine and will do what they will. We do not encourage them to be involved with our work.
May I add?
Thank you, Senator.
May I add something?
Senator slash doc, no, sorry, we're out of time, and we go to the next senator. Senator Dr. Osler for 1 minute, 46 seconds.
Thank you, Chair. And my question is for Dr. Green, and it's to follow up on something that you had mentioned in your opening remarks. Is there peer-reviewed empirical evidence that talks about socioeconomic vulnerability and marginalization as drivers of requests for MAID?
Thank you for the question. There's actually some very good data on this exact question that has been grossly misinterpreted and put out there. Dr. James Downer has a number of publications where he reviews the data and clearly states that those who are receiving MAID in this country are the socioeconomically advantaged. It's very clear they're more likely white, they're more likely well-educated, they're more likely socioeconomically, financially stable, they are less likely to live alone. There's a number of parameters he's proven over a number of papers. So I think that's been very clear.
I'm going to ask you a question I asked in the first panel about criticism that the CAMAP curriculum has not dealt appropriately with ableism that is embedded in our society. Can you respond?
Yes, I think there's been some question about that. I think that the working group 4, which Dr. Grubitz pointed out, did the most work on this. We had about, I don't know the exact amount of months, 18 months to 2 years of work. We had the input from a witness who came before this committee, which was very valuable and was incorporated in. I think we're better off for that. I think we've dealt with it. I think the outline will demonstrate to you the number of times that vulnerability, ableism are commented on and dealt with in the curriculum. I think Dr. Grubitz has addressed the rest of that question.
How many hours is...
Your time is up.
I wish to thank our witnesses. I will now suspend in order to proceed with our second panel. Merci.
Thank you.
Thank you for the second panel. So as individual, we'll hear Dr. Ileana Close from Australia. Representing 998, the Suicide Crisis Helpline, Dr. Alison Crawford. And from the College of Physicians and Surgeons of Nova Scotia, Dr. Douglas Grant. So the floor is yours, Dr. Close.
Members of the committee, thank you for the opportunity to appear before you today. I'm a researcher at the Australian Centre for Health Law Research at Queensland University of Technology in Brisbane, but I'm originally from Calgary. I did my undergraduate degree at the University of Calgary and my law degree at Oxford as a Rhodes Scholar. I articled at the Alberta Court of Appeal and was a Crown prosecutor in Alberta, and then immigrated Australia and entered academia. I have a PhD and I have been researching end-of-life law, policy, and practice for the last 14 years with a focus on assisted dying. Over the past 5 years, I led a Canadian case study on MAID as part of a major Australian Research Council project on the optimal regulation of assisted dying. The study included law and policy analysis and qualitative interviews with persons engaged in MAID delivery and regulation. I've published extensively in this area, and I appear today in my personal capacity as a researcher. I want to offer the committee 3 interconnected messages that have come out of my research. First, regulation of MAID is much broader than law alone, and that matters enormously for assessing readiness. A recurring error in public debate is to treat the criminal code as the only regulatory tool for MAID. But regulation is about shaping and steering behavior and encompasses far more than just legal rules. Guidelines, training, institutional practices, and communities of practice are all part of regulation. Optimal regulation includes both detecting transgressions and promoting best practices and continuous quality improvement. One cannot and should not put everything in the law. Readiness for MAID for mental illness as a sole underlying condition should therefore be examined holistically by looking at the whole regulatory ecosystem. Second, oversight and monitoring of MAID in Canada are robust, and the system already has considerable strengths. I've published several articles on oversight and monitoring, and here it is worth being precise about terms because conflation of monitoring and oversight is common. Monitoring is about aggregate data, tracking who's accessing MAID and under what conditions. Oversight is about review of individual cases for compliance with law and applicable standards, and both are important. Regarding monitoring, Canada's federal system is rigorous. Preliminary assessors, MAID assessors and providers, and pharmacists all report to Health Canada. MAID is one of the most comprehensively reported medical practices in the country. All requests are reported. Multiple practitioners report on every single case, and Health Canada's annual reports on MAID are among the most detailed in the world. Regarding oversight, over 90% of MAID cases have some form of retrospective oversight, and this is because the most populous provinces have bodies that do this. Quebec's Commission on End-of-Life Care reviews every MAID case and publishes reports. Ontario's chief coroner has a MAID review team, the MRT, which is different from the MAID Death Review Committee, which has a different role. The MRT is a team of nurse coroners that reviews every case and produces annual reports. British Columbia and Alberta also review every case. These are meaningful mechanisms of accountability and scrutiny. Third, coalface regulation is a critical and underappreciated component of MAID regulation. Some of the most powerful regulation in medicine occurs at the clinical coalface, in other words, the front line of healthcare delivery. Coalface regulation extends formal regulation into day-to-day practice and includes clinical practice recommendations, peer consultation, and best practices established by MAID teams in institutions and health authorities. For example, Nova Scotia has a single province-wide team that is aware of every MAID case and provides prospective support and retrospective quality review. In summary, Canada's MAID system has real regulatory strengths, strong oversight, comprehensive monitoring, and a layered ecosystem. The challenges for mental illness as a sole underlying condition are genuine, and they call for targeted regulatory responses. And while the criminal code sets the framework, it is mechanisms like clinical guidance and coal-face regulation that are best placed to deliver them. I welcome the committee's questions.
Thank you very much, Dr. Claus. Dr. Crawford. 4 minutes and a half for 45 max.
Okay, good evening, committee members. My name is Dr. Allison Crawford. I'm a psychiatrist and the Chief Medical Officer for 988, Suicide Crisis Helpline. I'm a professor at the University of Toronto and also the principal applicant on a CIHR-funded study examining MAID and suicide in the crisis line context. I'll be direct. I do not believe Canada should expand MAID to include those whose underlying condition is a mental disorder, and I'm basing that on 4 core points. The first, what we're seeing at 988, the absence of evidence that requests for MAID for mental disorder can be reliably distinguished from suicidal intent, shortcomings of recent clinical guidance, and public health and media risks. First, frontline signals from 988. Up to 7% of interactions on 988 refer to MAID. Critically, among those who reference MAID, 74% endorse thoughts of suicide in the past 2 days, compared with 48% among other contacts. In short, interactions with our national suicide crisis line that reference MAID are associated with substantially higher suicidal ideation. That's not a theoretical concern. It's a real, measurable, elevated risk among people who mention MAID to Canada's Suicide Prevention Service. Second, we know that suicidal thoughts and behaviors are very common across psychiatric diagnoses and are treatable. Our systematic review of peer-reviewed literature found no credible evidence that suicidal intent can be reliably distinguished from an interest in MAID when the sole underlying condition is a mental disorder. Both suicide and MAID represent an intention to die. Both often stem from the same underlying drivers: psychiatric disorder, intolerable suffering, hopelessness, perceived burdensomeness, and often social adversity. We also found no validated tools or assessment instruments that can reliably discriminate suicidality from a reasoned wish to die in the MAID context. Third, recent guidance from the Canadian Psychiatric Association does not resolve these clinical or operational gaps. The guidance is largely aspirational. It asks assessors to differentiate acute suicidal risk from a well-considered wish to die, but offers no operational framework, no clear criteria, and no specification of structured tools. The guidance also fails to incorporate a standardized equity assessment to determine when social determinants and remediable needs are driving suffering. In practice, this leaves clinicians without the evidence-based procedures needed to safely assess risk or to embed suicide prevention into MAID pathways. Fourth, there are public health risks in the way that MAID and suicide are discussed publicly and in the media. Our recent research, currently submitted for peer review, highlights that the media often conflates MAID with suicide or fails to use established, responsible media guidance for reporting on suicide. We lack guidance on safe communication about MAID and on preventing contagion effects, which should be a concern in making MAID for mental disorder an option. As MAID becomes more visible, the absence of responsible public messaging increases the risk that people will see MAID as a means of alleviating their mental suffering, and this will undermine suicide prevention efforts. Additionally, we must also acknowledge current system realities. Mental health services across Canada remain under-resourced, with long waits and inequitable access. These circumstances can produce or exacerbate the suffering that may drive MAID requests and suicidal thoughts and behaviors. My recommendation is straightforward. Do not expand MAID to cases where the sole underlying condition is a mental disorder. This recommendation aligns with the position of the International Association for Suicide Prevention that the overlap between MAID requests and suicide makes distinguishing between them impossible, and that MAID for mental illness will undermine suicide prevention by positioning MAID as a viable alternative to treatment. Suicide is preventable. The vast majority of people who contemplate or attempt suicide do not go on to die by suicide. Public health approaches to suicide prevention have been a priority in Canada, which is one of the reasons that the establishment of 988 received unanimous support in the House of Commons. Given the significant overlap between suicidal thoughts and behaviors and MAID, we will best serve those who are suffering with enhanced suicide prevention efforts, and by shifting our focus to medical assistance in living. That is what Canadians deserve. Thank you.
Very much, Dr. Crawford. Now we go to Dr. Grant, who is also a representative of the Federation of Medical Regulatory Authorities of Canada.
Thank you. I'm the Registrar of the College of Physicians of Nova Scotia, have been since 2011. Before that, I practiced law and family medicine for many years. It's a privilege to make these submissions. The committee has read into its record a letter from the Federation of Medical Regulatory Authorities of Canada. I was one of the signatories to that letter to summarize its essence. Wherever the law lands on medical assistance in dying, the regulatory colleges will be ready. My submission, and I'm here on behalf of my own college, is that the college in Nova Scotia will be ready because it's our legal duty to be ready. As a medical regulator, our college must keep pace with change in medicine. Otherwise put, medical regulators can't be the rate-limiting step for medical progress. We haven't been for MAID, and we won't be if MAID changes. And recent history supports that. When the world changed with the pandemic, the regulators were actually the enablers of medical change. I think of the hours spent on vaccine mandates, on public health orders, on virtual medicine, on remote prescribing, on all the things that were required in the moment to make medicine work. The regulators were at the front of that. But for MAID, additional time won't help us. Additional time in and of itself will not materially advance the regulation of MAID in Nova Scotia. If the law changes, we'll make the necessary regulatory changes, which will involve changing professional standards, communicating with the public, communicating with the profession. We'll respond to questions from the public. We'll investigate complaints to hold physicians accountable. We'll do what's necessary. I think on the surface, Nova Scotia's regulatory experience with MAID has been smooth, as has been the country's as a whole. At each punctuation mark, we've made the necessary changes in standards and communicated with the profession. We've kept step with the law. We've kept step with practice. Since it was introduced, since MAID became part of clinical medicine in Nova Scotia, our college has investigated, I think, around 4,000 complaints. 3 of them have involved MAID, and all 3 involved cases where family members were unable to access an assessment for MAID by a conscientiously objecting physician. These complaints were resolved through advice and education, not through discipline. Most regulation takes place behind the scene, and I appreciate Dr. Close's comment about regulation at the coalface. For me and for MAID, there have been lots of meetings to provide advice, engagement with advocacy and faith-based groups, discussions with institutions seeking to assert institutional rights of conscience, to assert policies inconsistent with the law. Some of these meetings have been difficult, but overall, the regulatory burden associated with MAID has been less than this chamber might anticipate. When I spoke to this committee, and I think I've given evidence 2 or 3 times now to this committee or predecessor committees, the questions of regulatory readiness were raised at each significant juncture, each significant punctuation mark with MAID. They were raised following the Carter decision. They were raised in the debates about C-16 and C-7. They were raised in contemplation of Audrey's amendment. And at each time, the question of, at least in my experience, each time I was asked questions about regulatory readiness, it came from voices known to be opposed to MAID for other reasons. And I hope and urge that this committee will examine the question of readiness as readiness per se, and not as a proxy for other reasons. I see 4 domains of readiness. The first is legal, and the Carter decision is your foundation. The second is political, and by the way, I'm grateful for the service of the people sitting in these chairs to work on the questions of political and legal readiness. The third is regulatory readiness, and I really appreciate Dr. Close's analysis of the matrix, the filters, the various levels of regulation. But from the pure medical regulatory authority's perspective, I'd submit that that shouldn't be determinative of your deliberations. And the fourth, of course, is clinical readiness, and you're clearly hearing significant evidence about that. I would submit that Nova Scotia's clinical approach is extraordinarily robust. and I have tremendous confidence in it, but that's for your decision to make.
Thank you. Thank you, Dr. Grant. So we're ready for the questions now. So the first questions will be from Mrs. Jensen. 4 minutes, 15
Thank
seconds.
you. Dr. Crawford, you said that up to 7% of calls to Canada's suicide crisis line have people mentioning MAID as an option. And the majority of those callers had thoughts of suicide in just the previous 2 days. So if I understand that right, when MAID comes up in those 988 calls, you're talking to people who are much more likely to be in an acute suicidal state compared to the ones who don't mention it. Is that a fair understanding of what your data is showing?
Yes, I mean, we're still analyzing this as we go. As you know, 988 is a relatively new service, but we've had almost 900,000 calls and texts to the service. So 7% represents almost 70,000 call interactions. And what we're finding is that when people reference MAID, they have a much higher degree of suicidality than callers and texters that don't reference MAID. And I think the key point here is that people make a lot about being able to distinguish suicidality from an interest in or a wish to die due to MAID. And we are seeing a great deal of overlap in those populations, and that clearly suffering, but suffering that overlaps.
Okay. Dr. Crawford, the way that MAID is talked about in the media, it seems that they're completely unaware of the danger of suicide contagion. We hear and see portrayals of MAID in serene and dreamy surroundings with the idea that this kind of death is heroic and self-sacrificing, which is, of course, very opposite to the suicide prevention messaging. Normally, we don't amplify or glorify the actions of, say, a shooter, for example, in order to avoid copycat behavior. How real is the risk of suicide contagion with our media reporting and messaging, and what immediate communication safeguards should be in place to prevent that kind of effect?
Yeah, so Canada and internationally, we've made great strides in responsible media practices when media mentioned suicide. But when we looked at articles that mentioned both MAID and suicide, we really found that those safe and responsible reporting practices were not followed. There was a glorification of death. There was a lot of stigmatizing language in a vast majority of articles. And we know that those have very real effects. Certainly in the suicide prevention world, that is a demonstrable effect called the Werther effect that results in many deaths. And this does apply to MAID. We've already seen that in the Netherlands when there are, high media cases or with a lot of attention, we see increasing requests for MAID. So it's a very real effect, and we should be very concerned about contagion.
Yes, when the Simons advertisement came out, which definitely glorified MAID for somebody, could you see in the calls to 988 that there was an impact with that?
So we didn't look at that specific ad campaign, but we have looked at different legislative time points, and we can definitely see an impact. In media reporting, not to 988. We have not looked at that in terms of calls to 988.
Okay, and what specific evidence gaps did your LIT review identifying about distinguishing MAID requests from suicidal intent? And what would be required to fill those gaps?
Right. So we just completed a systematic review of the literature and really found a lot of overlap and inconsistency in how research, the published peer-reviewed literature, was talking about and defining suicide in relation to MAID. So I think in many of these debates, it's treated as that they're very distinguishable, but in the scientific literature, that distinction is not clear. We also found no standardized tools that could reliably distinguish between suicide and an interest in dying from MAID. And I'm not sure that we can get there in terms of being able to distinguish between them. I think they are overlapping concepts. They're both an intention or an interest in dying. And they're both like signs of despair, deaths of despair.
And where does the Canadian Psychiatric Association guidance fall short in practice?
In 5 seconds.
Well, I think primarily the concern is that it tries to say that a gap has been filled that has not been filled, that it tries to advance that we are closer to making those differentiations around irremediability and suicide.
Okay, thank you very much. The next round of questions is from Dr. Polonsky.
And I have to say, co-chair, as a greenhorn in this business, I think you're doing real well. For those who don't know, he was the Quebec Court of Appeal judge before he came here. So the question is whether, he's going to hit me with the hammer next, whether we should expand MAID for mental illness, very obviously, and certainly we've heard from Professor Close about the comprehensive oversight that's available in Canada. Dr. Green talked about the robust professional oversight. Dr. Grant, you talked about being ready. There would be professional oversight. It's hard for me to believe, given the kind of oversight we've been seeing with MAID currently in Canada and the lack of cases that have come before the colleges of physicians and surgeons across Canada. For example, and Professor Close talked about the coroner MAID review team. According to them, there have been 14 cases referred by the Ontario Coroner's Office to the CPSO, and there's been, to my knowledge, no disciplinary action. And I've been a member of the College of Physicians and Surgeons of Ontario for 40 years. I know that the College of Physicians and Surgeons, if they have a medical complaint about my practice, that there will certainly be a review, and that'll be sent to all members of the College of Physicians and Surgeons. That doesn't seem to be the case with MAID. Similarly, a Freedom of Information request in BC in 2023 found that there were 24 cases referred to either the police or the College of Physicians or Surgeons or colleges of nursing about MAID practitioners. Again, seemingly no cases. There have been some pretty egregious cases. The case, which is currently in court, involving Dr. Wiebe, where there was a patient who was hospitalized for suicidal ideation while out on leave, went and saw a MAID practitioner and received MAID. Dr. Mahler, who's an ACT team doctor in Southern Ontario, talked about a patient of his with chronic schizophrenia that said, both he and the family physician said, clearly this patient did not meet any of the requirements to get MAID. However, he'd seen two doctors who'd been approved. When Dr. Maher went to the Ontario College of Physicians and Surgeons, who I might add have been asked to appear here, but have so far said no, they didn't want to appear. But according to Dr. Maher, when he went to the Ontario College of Physicians and Surgeons, they said, well, you'll have to wait till he's actually died before you can. I know, and you're looking at Dr. Grant. That's the way I feel.
1 minute and a half.
And I've talked enough, Dr. Grant. It's hard for me, given what we're seeing with MAID, to really believe there is going to be that oversight. I know maybe you haven't seen the cases, but tell me what you can to reassure me that there will be that oversight.
Well, the first thing is, thank you for the question. Decisions of colleges are only made public and circulated to the members when there's been a disciplinary finding. So the case you example, if there was concern about your clinical practice, it would only be circulated if there was a disciplinary finding. I think one of the things, in the brief amount of time allotted to me, I'd say that speaks well of the many layers of regulation that Dr. Close described. That if you look at a case in Nova Scotia, if you look at examples of medical assistants in dying in Nova Scotia, involved in that process would be nurses, nurse practitioners, social workers, two physicians of different disciplines. There would be, and each of those professionals would have would have first responsibilities employees of the health authority if they saw something amiss. They would have professional responsibilities as physicians do under the Canadian, under the CMA's Code of Ethics. They'd have professional standards as the regulatory body to report to them of themselves or of others of other regulated health professions if they witnessed something that was unprofessional. They'd have duties as citizens when see something, say something. So there's many, many
The questions was very long, but
regulation.
unfortunately the time is running out.
Fair enough.
Thank you. Now we move with Madame de Bellefeuille pour 4 minutes, 15 secondes.
You have 4 minutes, 15 seconds. Thank you, Chair. Madam Close, I hope you have your interpretation device on. Your testimony really moved me because you said that legislators have work of setting out guidelines. But we also talked about the need to have a more holistic vision, to talk about the sufferance of individuals suffering from mental illness. And I recall the example where in my office, there's a person suffering from schizophrenia who came to see me and asked me if he could have MAID with visual hallucinations, auditory hallucinations, with paranoid ideas. But after 25 years of treatment, of medication, this person wasn't able to live without sufferance and just couldn't see a future for a whole range of reasons. This person really wanted to give their consent to MAID. And I had to say, well, it's not yet possible. Do you find that the assessment of sufferance is it up to practitioners to define this? And slowly but surely, work is advancing in Canada to provide a framework for this, to regulate this. And we're not actually talking a lot here about suffering. Even with personal support, there are people who continue to suffer and just can't go on anymore. Do you think that that's an important dimension of our discussions here this evening?
I do think suffering is important, and of course it's part of our criminal code and of our law. I'm obviously not a clinician, but the law tells us that individuals need to tell us that they're suffering. And while my research hasn't looked at the normative questions around MAID for mental illness as a sole underlying disorder, I know that that notion of suffering, and that some people that are suffering from a mental disorder may have intractable suffering and may still want that autonomous choice, is rooted in our charter, and that is why our court has decided that this is part of the law.
Dr. Grant, vous, votre position sur la question...
Dr. Grant, your question on the situation of someone suffering from an incurable mental illness who has endured this illness their whole life and has made every possible attempt to find medication, support, professional support. Do you think that such a person can choose to put an end to their life through MAID after years of suffering?
I should probably limit my answer. My personal answer is yes, but my answer as representing the College of Physicians and Surgeons is that I have confidence in the medical profession's ability to discern whether that patient can provide an informed consent for this.
Vous faites confiance à l'entourage professionnel.
So you're confident in medical services, in medical professionals, to help the patient take an informed and free decision?
Very much so. That, to me, informed consent is the cornerstone of the Canadian medical system. Physicians are trained, robustly trained, to identify decisional capacity of patients. We do it in many complicated scenarios, and this is one of them. But physicians are also challenged in many disciplines to determine whether patients can provide an informed consent. The mature 14-year-old who seeks transfusion or denies transfusion, the mature 13-year-old who seeks contraception, the suffering patient who chooses not to pursue potential life-saving treatment for chemotherapy. It's a regular feature of medicine to be able, and all health professionals, by the way, to identify whether the patient has decisional capacity and can provide an informed consent. And I worry that I believe this should remain in the hands of medical professionals.
Thank you, Dr. Grant. I need the consensus. Is there consensus or consent that we go till 8:20 and then adjourn for the vote? We'll suspend for the vote? Yes, not adjourn, sorry. Yes, there's consensus, thank you. So now we move to the Senator.
Senator, for 3 minutes, Dr./Senator Moody, please.
Thank you, Chair. My first question is for Dr. Grant. We've heard testimony from John Mayer mentioning a case he claimed he was aware of in which MAID was offered to a 30-year-old, someone he claimed he called the College of Ontario on, and they said something about the patient was not dead yet, so they couldn't do anything. What would a physician do if they believe that another clinician is not complying with the criminal code provisions we made? What would your college, and I presume other colleges like yours, what would you do if presented with an allegation that a clinician is operating in a way that has already breached the criminal code or is going to?
We'd investigate, and we'd investigate quickly. At the risk of repeating what I said to the previous question, physicians have a duty to report. That's a professional standard all colleges have. Physicians have a professional and ethical duty to report, which is embedded in the CMA Code of Ethics. Physicians working in health authorities have safe disclosure or whistleblower responsibilities throughout, as do all the other health professionals. So I have a hard time envisaging a situation as described by the previous question where the regulator, the health authority, the other professionals involved are blinded to this unprofessional conduct. But short answer to your question is if we received that phone call, we'd investigate immediately.
Thank you. Dr. Close, this is a question for you. You've talked a lot about the importance of cold face regulation. Does that mean that you expect that there'd be variability across the country? And does that strike you as a problem where cold face is an integral part of the complete package of oversight and regulation that you refer to?
There is variation across the country. We are a federation, and ultimately provinces and territories have made different decisions about how to invest their MAID programs and how some of this cold face regulation operates. I don't think variability is necessarily a problem because ultimately it's up to the provinces to decide how to deliver MAID. And depending on the local context, different mechanisms of regulation can be more appropriate. Some provinces have very low cases of MAID, but the very fact that there's variability should not be cause for concern on its own.
Thank you. Do I have time,
15
Mr.
seconds.
Chair? Dr. Grant, are you aware of any cases in your college or colleges across the country where MAID physicians have committed the crime that was described by John Mayer in his past testimony?
I'm aware of none, though I take note of the case referred to in the previous question in British Columbia.
Thank you.
You, Senator Osler, for 3 minutes, please.
Thank you, Chair, and thank you to all the witnesses. My question is for Dr. Close. 5 minutes is a very short period of time, and you tried to cover as much of your research and analysis as you could. But can you share with the committee if there are other key aspects of monitoring, oversight, and regulation that you think is important for this committee to understand, particularly as it applies to MAID with mental illness as the sole underlying medical condition?
Can I just clarify what you mean by other aspects?
Can you share with us anything else in terms of monitoring, oversight, and regulation that you want us to know?
Thank you. One thing I think that gets underappreciated as well is that this existence of no escalation or disciplinary consequences from the colleges gets used to suggest that they are looking the other way and that problems are not being detected. What is often happening, and what we know from the Ontario MAID review team data, is that tiered responses happen when matters go to regulators. So often it's administrative errors that are occurring, and these are easily and quickly addressed by things like an educational email, a phone call. And this is normal in regulation, this type of tiered response. The Ontario review team data, which I can provide to the committee, also says that no MAID cases have been escalated to the police. And again, that gives me confidence that these mechanisms are working. It's not that things are being covered up, but it's just that they're not occurring. So that tiered responsive mechanism is really important to know. So when we're looking at the data, we need to look at those reports and see what is actually going on in practice.
Can you respond to any of the implications that colleges are looking the other way or that cases are not being taken seriously?
All
Look,
I can speak to is my own college. We take them very seriously, and I've had in Nova Scotia's. I've had the benefit of working closely with the MAID team in the development of their clinical standards and working closely. And we have this device in Nova Scotia called a phone. And when there's difficult cases, I'm often phoned by clinicians to say, "Hey, Gus, how do you think we should proceed?" So I think Nova Scotia enjoys a very close relationship between the regulatory body and the health authority and the clinicians delivering the care. So I have not had, I would say just the opposite. We're not turning away, we're leaning into these cases, and I'm grateful to have the opportunity to do that.
Thank you, and Senator Wells for your 3 minutes.
Thank you. Dr. Close, this committee has heard from multiple witnesses that the current safeguards to protect against illegal MAID assessments have fallen short. Based on your research and the empirical evidence you referenced in this meeting, what recommendations do you have for any additional safeguards or other forms of regulation that we should be considering for MISUMC?
I don't think that additional safeguards are warranted in the law. I think that the system has enough safeguards. I think what needs to happen is there needs to be more transparency in provincial oversight. I think we've got good data from, say, Ontario that I understand the coroner will make publicly available from the May Death Review team. I think there needs to be these networks of accountability mechanisms which exist already but can be reinforced, and that requires investment from the provinces. Ultimately, that's a provincial decision. But, you know, I think these mechanisms are more flexible and appropriate to deal with complex cases, and they're not additional legislative safeguards.
Thank you. Dr. Crawford, suicidality is not uniquely associated with mental illness, as we've heard from previous experts. When your organization receives phone calls asking questions about MAID, how is your organization providing accurate and objective information to those callers?
About MAID?
Yes.
Yes, we do not. So we have an explicit policy that we treat every instance as an opportunity for suicide prevention.
So you wouldn't refer them to any MAID appropriate services? Okay. Thank you for that. Dr. Grant, at our last committee meeting on April 21st, one witness stated in their testimony that clinicians cannot be entrusted with the great power and responsibility of MAID MISUMC. How would you respond to that criticism?
Boy, hard to respond to it because I don't know the basis on which it comes. Clinicians are licensed with an extraordinary depth and range of responsibilities that involve life and death across a number of disciplines. I don't know how, why this is distinguishable.
Thank you. And just to reemphasize what you said, the regulators are ready and will enact this law should Parliament move forward.
We're awaiting instructions.
Thank you.
Thank you. Back to the second round.
Yes, thank you. Mr. Lawton for 2 minutes, 33 seconds.
Thank you. Dr. Grant, Senator Moody asked you if you had referred to you criminal misconduct or allegations of criminal misconduct, what you would do. And I want to confirm that I understand your answer was that you would investigate it internally and not refer it to police. That is what you said twice.
Well, if I did, then I misspoke. What I would do is if we have a concern that arises to us, if it's on its face criminal, we immediately phone the RCMP. Okay. We get it quite often in other domains of regulation. So what we will do is typically, if there's merit to the concern, we'll take interim sanctions if those are available to us, as in suspend the physician's license, and then refer to the RCMP or law enforcement.
I'm relieved to hear that. Thank you.
Sorry if I misspoke.
Dr. Close, and just for clarity, you have a PhD, not a medical doctorate, correct?
Correct.
Okay. I want to talk about the very important question here of physician readiness. And this is not from people on the outside of the system looking in. These are comments made by MAID assessors and practitioners in your own research. One, we are not infallible. There are stupid clinicians. We need to make sure it's done well and oversight's mandatory. Maybe I've been doing, another one, maybe I've been doing things wrong for 5 years. I don't know. Another one, I agree there's oversight on my ticky boxes,
but there's no oversight on the quality of my work. How do you rationalize your claim that there is robust oversight already when the practitioners cited in your own research would seem to contradict that thesis?
I think it's important to take that research in its context, and those participants were talking about different oversight mechanisms and making more general comments. With respect to the comment about we don't know if there's oversight on my ticky boxes, that was specifically a comment on the lack of transparency in the British Columbia processes. So I wholeheartedly support more transparency around that. But these comments were also illustrating that oversight shouldn't just be about, did I follow all the elements of the criminal code? Oversight should also be about continuous quality improvement and learning from mistakes. And that is where there is a role in Canada that we are seeing is there, but could be bolstered.
I only have 10 more seconds here. You mentioned retroactive oversight. To be clear, that would be oversight when the patient is already dead, correct?
Retrospective, yes. After the patient is dead, yes.
The next, probably the last one before the break, will be Dr. Jezik.
Thank you so much, and thank you to the witnesses. Dr. Close, you've talked about regulation of MAID, guidelines, training, best practices. Would it be helpful to, in the case where the sole underlying condition is a mental illness, to have some sort of documentation? In Ontario, I believe there are clinician aids essentially documenting that the clinician has gone through a whole series of questions around the reason for the request for MAID. In other words, in the case of a mental illness, documentation that so many treatments had been provided with details and so on, and had not been successful. I'm thinking of sort of the chronic schizophrenic that has tried everything, including electroshock, etc. Would it be helpful to have a uniform kind of assessment tool that was in writing, was or digital, that was available for review?
I think that regulatory design and system design is an important part of regulation. And so forms can help clinicians know that they are going through the required steps that they should be going through. I don't think that there could be a form that could say you must go through and try 5 different treatments before this is allowed. I think that would be overly prescriptive. But yes, I think that the form itself can be a way of translating legislative safeguard or other best practices so that clinicians are going through those steps.
Dr. Grant, do you in Nova Scotia as a college have any requirement for sort of very specific steps that under the current situation with MAID that a clinician is required to go through?
Our professional standard, which is on our website, available to the public and to the profession, is very prescriptive. It's quite step by step. It very much aligns with all of the legislation in the Carter decision, and it's the foundation for the clinical protocols in place at the Nova Scotia Health Authority. So ours is just the professional standard.
And that you would create such a standard for a sole underlying condition, mental illness?
I think we probably just adopt, I'm certain we would adopt or adapt the one we have in place.
Yeah. No more further questions.
Thank you very much. So we're going to suspend for the vote in the House of Commons. For the witnesses, please stay and stand by because we're going to resume after the vote about 15, 20 minutes from now. Thank you very much, and sorry for the interruption. We're resuming. Merci. And thank you very much to all the members of the panel that has been waiting patiently for this panel and the next panel. But there was a vote and we have to suspend. So there's only three questions left for this panel. And the first will be from Madame de Bellefeuille, s'il vous plaît.
Merci, Monsieur le Président.
Thank you, Chair. Dr. Grant, if I asked you, you said that Nova Scotia was ready if ever legislators decided to admit mental illness to MAID. You said that you'd be ready in Nova Scotia. If we recommended the broadening of MAID, would you be worried that there would be some kind of suicide contagion in Nova Scotia, that somehow MAID applied to these illnesses would encourage people to commit suicide?
No, but I would not be worried about that, but I'm not a clinician working in that space. I would be confident that the assessment for eligibility for MAID would be done in a reasoned way. And as we were saying in the break, a patient whose sole underlying medical condition is a mental disorder, that's not a patient being assessed for MAID at 3 in the morning by an emergency department physician. That's an assessment made over time by two separate clinicians after there's been a demonstration of enduring suffering and marked decline. So, no, I would not be worried about that. Merci.
Senator Moody for 1 minute and
42 seconds.
1 minute 42 seconds.
My question, thank you, Mr. Chair. My question is for Dr. Grant. Would your college look to guidance documents from professional associations when setting your own practice standards and assessing clinician practice? Dr. Grant?
Absolutely. When we developed our professional standard on MAID initially, and it's been edited a number of times over the years as the law has changed. We started with the decision in Carter. Then we looked at Bill C-16 and C-7. We had consultation with the CMPA, the CMA, various stakeholders throughout the space, and then. The beauty of being in a small province like Nova Scotia is I've had the benefit of working closely with the clinical team and the administrative team that oversees the delivery of medical assistance in dying. So, yes, it's very much a collaborative effort.
And I know that you meet with your colleagues in other colleges from time to time. When you meet with your colleagues from these other regulatory colleges across Canada, does MAID practice stand out as an area of poor practice with unethical and unprofessional practices common?
Sorry, I didn't hear what you said. No.
So when you meet with your colleagues, are you talking about MAID practice as standing out as areas of poor practice with unethical concerns on professional practices?
No,
very shortly.
I would say no. Quite frankly, the opposite. It's an area where really passionate physicians are drawn to work.
Senator Osler for 1 minute 42 seconds.
Thank you.
Thank you, Chair. Dr. Grant, this committee has heard very different pictures of the safety of MAID practice from a regulatory point of view. How do you, as a regulator, reconcile these very divergent views?
It's hard to answer to the effect of anecdotes that I know nothing about, right? And there's I was saying earlier, there's a arithmetic of compassion that one extraordinary story can have an enormous influence against thousands of other cases. I think MAID in the context of all of the medicine that's being delivered, the ever-changing, progressive changes in medicine, is extraordinarily regulated and monitored. And I really do admire the testimony given by Dr. Close earlier about, I hope the committee appreciates the levels, this matrix of regulation that takes place on from the coalface all the way up to the regulator's desk.
Thank you, Dr. Grant. Thank you, Chair.
Thank you.
So that completes the second panel. I want to thank on behalf of the committee all the members of the panel. Thank you very much. We'll adjourn for a few minutes to board the third panel. Suspend, sorry,
Mr.
for
Chair,
a few minutes.
if I may, at the beginning you introduced me as speaking on behalf of the Federation of Medical Regulatory Authorities of Canada. I was invited as the registrar of the College of Physicians and Surgeons only.
Thank you very much. Suspend. I wish to welcome our witnesses that are with us tonight for our third and last panel for today. Appearing as individuals, Dr. Jitender Sareen, Head of Psychiatry and Professor, Department of Psychiatry, University of Manitoba. Dr. Sandip Singh Ganham, Assistant Clinical Professor, Department of Family Medicine, University of Alberta. Representing the Ontario Hospital Association, Melissa Prokopi, Vice President, Policy and Advocacy, and Dr. Kevin Young, Vice President, Medical Affairs. Dr. Saran, you have 5 minutes.
The invitation to appear today. My name is Dr. Jitender Sareen. I'm speaking as Department Head of Psychiatry at the University of Manitoba and as the Provincial Specialty Lead for Mental Health and Addictions at Shared Health. I have practiced adult psychiatry for more than 25 years. My perspective today reflects my clinical, research, and system experience rather than a philosophical or conscientious objection to MAID itself. MAID for mental disorders has been a difficult issue in Canada, and there are thoughtful perspectives on both sides. I respect concerns about autonomy and suffering associated with mental disorders. However, after careful, unbiased review of the international literature, I believe Canada should not expand MAID to include mental disorders as a sole underlying condition. First, prognosis in mental disorders is often uncertain. Individuals can remain severely ill for long periods and still improve, particularly with changes in treatment and psychosocial situation. There is no international standard that defines irremediability in mental disorders. I want to repeat that because when you're regulating something, unless you have an international standard to hold somebody accountable, you cannot regulate it. Second, there is also no clear and reliable way to distinguish a request for MAID for suicidality when mental disorder is the sole underlying condition. Unlike physical conditions, suicidal ideation is part of the diagnostic criteria for many mental disorders, including depression, post-traumatic stress disorder, and borderline personality disorder. So, unlike physical conditions, suicide is part of the diagnosis. This goes to the core psychiatric practice, which is grounded in assessing and treating hopelessness and preventing suicide. I know you've been reassured by some other witnesses that psychiatrists are trained to make distinctions between MAID and suicide, but psychiatrists and psychiatry residents nationwide are not being taught how to distinguish MAID from suicidality because there's simply no way to do it. Most academic chairs of psychiatry departments across Canada have similarly recommended against expansion of MAID because of these concerns. Third, most international professional associations and people with lived experience groups have clearly recommended against providing MAID for mental disorders. In 2025, the American Psychiatric Association's position paper has explicitly opposed this, citing the difficulty in defining irremediability, the unpredictability of prognosis, and the concern that mental disorders itself may influence decision-making. The International Association for Suicide Prevention has also expressed opposition to MAID. In Canada, both the Canadian Association of Suicide Prevention and the Canadian Mental Health Association have raised concerns about expansion, alongside organizations representing people with lived experience and disability advocates such as Inclusion Canada and Indigenous Disabilities Canada. In 2023, Quebec has passed Bill 11 that a mental disorder other than a neurocognitive disorder cannot be an illness for which a person may request MAID. This year, Alberta has proposed Bill 18 to exclude MAID for mental illness and to restrict access to MAID for individuals with a foreseeable death in the next 12 months. Speaking for Manitoba, when this issue was brought to our Provincial Psychiatry Leadership Council in 2022 and again in 2026, in the context of operational planning, the Council reached a clear consensus on both occasions that expansion to mental disorders should not proceed. For these reasons, I respectfully urge this committee to recommend an indefinite pause on the expansion of MAID for mental disorders. Thank you.
Thank you very much. Now, Dr. Ganham.
Honorable Chairs, thank you for inviting me to appear before you today. I appear before you today as an individual. I'm a family physician with experience working in addictions medicine, mental health, and end-of-life care. My perspectives are shaped by providing care for those with profound suffering, including expressed wish to die. I've also worked as a MAID assessor and provider since 2016. I come to the discussion not as an ideologue, but as a clinician who has sat with suffering in many forms, physical, mental, existential, and social. I want to begin by acknowledging something very important. Suffering associated with severe mental disorders can be unbearable. Those of us who provide care for those with severe chronic mental illness know this firsthand. Their suffering is real. It is not less real because it is psychiatric rather than physical. Recognizing that suffering is one of the reasons many support MAID for where mental disorder as a sole underlying condition. The potential benefit, ethically speaking, is the respect for autonomy and also equal treatment. If a grievous and irremediable suffering is the foundation of MAID eligibility, some argue it would be discriminatory to categorically exclude those whose suffering is solely from mental illness. There's also an argument rooted in compassion. For a small subset of people whose suffering may truly be enduring, refractory, and intolerable despite years of care, MAID may be seen as a last resort to relieve their suffering where other medicine has failed to relieve. Those arguments deserve serious consideration, but so too do the risks. In my view, and from my clinical experience, the risks of proceeding currently outweigh the potential benefits. And these risks are not just incidental, they're fundamental. It begins with the concept of irremediability. In many physical illnesses where MAID is currently provided, prognosis may be difficult, but it is often more knowable. In psychiatry, by contrast, predicting that a person's suffering is truly irremediable is far from certain. Recovery in mental illness can be non-linear and surprising. Patients who at one point seemed like they had beyond hope may later improve from treatment, sometimes because their circumstances change. Housing stabilizes, trauma is addressed, substance use remits, relationships repair, hope returns, and sometimes simply from the passage of time itself. I've seen patients who have once believed death was their only relief later find stability, meaning, and reasons to live. That uncertainty matters deeply when the intervention being considered is irreversible. A second concern is many features of severe mental illness can directly affect the wish to die. Hopelessness, self-destructive thinking, impaired future orientation, suicidality, all of these can be symptoms of the illness itself. Particularly in addictions medicine, I see how suffering can distort what appears to be a settled wish for death. Distinguishing a sustained, autonomous wish to die from a treatable expression of an illness is not a simple assessment challenge. It is often the core clinical question. And so I worry in some cases we may not be responding to an autonomous, enduring request for assisted dying, but rather the voice of the illness itself. That is not a distinction we can afford to get wrong. Thirdly, I'm deeply concerned about structural vulnerabilities. Requests for death, they don't arise in a vacuum. They may emerge in the context of trauma, poverty, isolation, inadequate housing, long waits for treatment, lack of access to care and supports. If people seek MAID because they cannot access the conditions necessary to live with dignity, that is not a triumph of autonomy, it is a failure of care. In such cases, the suffering may be real, but its drivers may be remediable through social response rather than death as a medical intervention. That raises a profound ethical concern. Are we offering MAID in some cases because a person's suffering is truly irremediable, or because our systems have been unable or unwilling to provide what they need to live? And I would submit that Canada has not yet demonstrated a mental health and social care system robust enough to assure those alternatives are meaningfully available. Some may still argue that this is discriminatory. I would respectfully suggest caution is not discrimination when it arises from genuine clinical uncertainty and concern for protection of the vulnerable. Equal respect does not always require identical responses when the underlying clinical realities differ. For me, the question is not whether some people with mental illness suffer grievously. They do. The question is, can we reliably distinguish in practice those rare cases where suffering is truly irremediable from those where despair may yet be treatable? And I'm not persuaded we can do so with sufficient confidence. And so, where doubt exists in matters of life and death, where prognosis is uncertain and vulnerability is profound, caution is not paternalism. It is an ethical responsibility. Thank you.
Thank you very much. We'll now proceed with questions. Sorry, Ms. Prokopi. Ms. Prokopi.
Thank you so much for today's invitation. I am Melissa Prokopi. I'm the Vice President of Policy and Advocacy at the Ontario Hospital Association, and the OHA represents Ontario's 135 hospitals. Our membership includes a diverse representation of hospitals of various types and sizes, including mental health and addictions hospitals. I'm joined today by Dr. Kevin Young, who's the Vice President of Medical Affairs and Chiefs of Staff at Waypoint Centre for Mental Health Care in Penetanguishene, Ontario. Today, we'll share with you perspectives from the hospital sector about the Ontario healthcare system's readiness for the proposed expansion of MAID, where mental illness is the sole underlying medical condition. I want to outline 3 key concerns we have heard from our hospital members with respect to the proposed expansion, including existing challenges to access to mental health care services more broadly, the impact of inequities in accessing these services by different parts of the population, and broader system readiness by healthcare providers to deliver MAID. I'm going to ask Dr. Young to outline these access and equity points in more detail.
Thank you, Melissa.
With respect to access to mental health care services, there are still significant barriers in Ontario and across Canada. Recent data from the Canadian Institutes of Health Information reveals that 41% of adults aged 18 or older that are diagnosed with mental health disorders say that their needs were only partially met or were completely unmet. These challenges are relevant not just on a patient level, but also when looking at overall system readiness. For example, in 2024, the OHA commissioned a study with the University of Toronto which examined the expected impact of chronic illness on the healthcare system in the next 20 years. Mood and anxiety disorders and substance use disorders were noted to be contributing to the rise in chronic disease among young Canadians. This means additional strain on the health system and an increased need for improved access to mental health care. Additionally, we heard that existing challenges in accessing care can complicate the provision of MAID. They also present challenges for healthcare providers in eligibility assessments. Healthcare providers must be assured that MAID is not chosen by patients simply because they cannot access necessary mental health care. Clinical challenges caused by inadequate access to mental health care can cause further system impacts. For example, a patient might be found to be ineligible for MAID but continue to have issues accessing mental health supports. Practitioners may be required to address access issues in the MAID application process through facilitating consultations or seeking expedited treatment for applicants, which may be the best course of action for that particular patient. But this could also create the risk that the process becomes a means to access mental health care more quickly, which can then further increase inequities in accessing care. It's also important to consider equity in access to mental health care. As we know, systemic inequalities such as racism, poverty, homelessness, and others can worsen mental health. For example, Statistics Canada reported in 2024 that for Indigenous people who required or were seeking mental health care, the vast majority, approximately 3/4, reported that their needs were unmet or partially met. The federal government recognizes the significant barriers facing Indigenous peoples in accessing mental health supports. These barriers are rooted in systemic racism, geographic location, and other structural factors. Past consultation by the federal government with Indigenous peoples on MAID underscored the need to improve access to mental health services and the need for further consultation on MAID expansion. Enhancing access to mental health care would help ensure MAID is truly informed and a voluntary choice. We believe that additional consultations should continue before the government makes any decisions to move forward with an expansion. I'll hand it back to Melissa now for some more information about system capacity challenges.
Thank you, Dr. Young. Our final point is that hospitals have identified clinical gaps that constrain system capacity. For example, we have heard that there is still no clear agreement amongst clinicians about determining eligibility for MAID, where mental illness is the sole medical condition. This includes how to decide whether a mental illness cannot be treated and how to tell the difference between a MAID request and suicidal intent. Further, we've heard about the need for clearer clinical guidance and training to ensure providers feel well prepared. One of our members, the Centre for Addiction and Mental Health in Toronto, has publicly recommended that guidelines must be consensus-based, given that there is a lack of evidence on this issue. For these reasons, we believe that more time is needed to develop consensus and ensure system capacity and preparedness. Thank you again for the opportunity to speak to committee, and we're happy to answer any questions that you might have.
Thank you very much for your presentation. We have agreed to go only one round because we're running a bit late, and the translator also are running late, but staying put. So we'll have a first round where each MP will have 5 minutes. You can share the time with somebody else if you want, another colleague. And senators will have each 3 minutes. So the first, I recognize first Mr. Layton.
Thank you very much, Mr. Chair, and thank you, witnesses. Just as a matter of context, Dr. Gandham, you are a MAID assessor and provider, correct?
Correct.
So when you come at your position of skepticism, it's not coming at all from anywhere near a conscientious objection to MAID itself?
Definitely not.
Okay, I appreciate that very much. And you've done events, I believe, with Dying with Dignity Canada, right? I have done. Yeah, thank you for that. I'd like to move to our witnesses from the Ontario Hospital Association, whichever one of you would like to take this. We heard earlier on from a witness who was for the expansion of MAID to people with mental illness that if individual practitioners don't feel ready, they should simply not be a part of the MAID regime. But for your members who are hospitals dealing with the same dissent that we've seen among witnesses on this community, how could a hospital even begin to move forward with this when there is no consensus within psychiatry, among the psychiatric community, and no consensus even among the MAID assessment community?
So I'm happy to start, and Kevin may have something to add as well. I will reinforce the point that I made that the Centre for Addiction and Mental Health has stated quite publicly, is that we need consensus. Part of the OHA's role in supporting 135 institutions across Ontario is to create, from an organizational perspective, a standard and consistent approach to how we navigate access to any service. But given the lack of clinical consensus across the board on MAID at an individual level, we think that the focus should really be on, at this point in time, broader access to mental health services across the healthcare continuum.
I know the system has accounted for individual physicians who don't want to participate in MAID, but at an institution level, if the expansion does go forward, are you convinced that hospitals would have the adequate legal grounds to say they will not participate because they do not feel ready to offer this, specifically referring to MAID for people with mental illness?
So I'll just clarify that the OHA is not a regulatory body, so we're an association. Certainly we represent all of the hospitals, and we have, and we're aware that a number of our hospitals are faith-based institutions, and we also know that these members are committed to respecting patient choice and providing effective evidence-based consultations for MAID. Our job is really to support those efforts within the organizations, and again, individual organizations make individual choices, so really our perspective and role is to help create a consistent, standardized approach as much as we can.
Thank you. I cede to Mr. Cooper.
Okay. Dr. Ganem, I just want to confirm that you are the provincial medical lead for MAID for Alberta Health Services and have been in that role since 2019.
I'm Dr. Serene.
Dr.
Yeah,
Ganem.
sorry, yeah.
Okay.
I am, but I am here as an individual, not representing them.
Thank you. Dr. Serene, in your professional opinion, does the CPA guidance evidence readiness for the expansion of MAID for mental illness?
I've reviewed the CPA MAID guidance document. On the front page, if you read it, it says it has not been peer reviewed. I'll stop there.
Okay.
But I will also add that CPA has, on their website, says that they don't have a position on MAID. So I think you've heard the testimony from a number of people saying there's no international definition around irremediability and differentiating MAID from suicide. So that guidance document is not peer reviewed. It's a small group of people.
And you were not consulted?
No.
Are you aware of other heads of psychiatry being consulted?
No.
Okay. And it copies and pastes Health Canada's model practice standard with respect to irremediability. Do you see that as an appropriate criteria, or is that problematic?
No, I don't see it as an appropriate criteria, and that's what the chairs of psychiatry have also submitted a briefing to this committee saying that we don't support expansion.
Yeah, and would you agree that you can look at past treatments,
right,
but the most important question is what is going to happen into the future, and that's something that the practice standard criteria does not address.
Exactly.
Okay. And what about on the question of suicidality? We heard testimony from the head of chairs of psychiatry that it actually creates clinical confusion. Would you concur?
Yes, I agree. Again, I repeat that the CPA guidance document has not been peer reviewed, and internationally, the documents that I've referenced, the American Psychiatric Association document, has been peer reviewed and approved by the APA board, and that is an International Association of Suicide Research as well. So I don't support that document from CPA.
Monsieur Fergus.
Merci beaucoup, Monsieur le Sénateur, pour
5 minutes.
Thank you. 5 minutes. Thank you. First of all, I'd like to thank all of you for being with us here today and to provide your views and provide testimony before us on this very delicate question. I'm very new here on this committee, and in the little time I've attended these discussions, I've heard that there's no consensus. There are healthcare professionals who say we are ready. There are regulations, there are rules that we can follow, and others say, no, we're not ready. Some people say that we have the capacity to provide these services, while there are others who say the exact opposite. Dr. Gundam, I'm grateful that you've taken into consideration the serious matter of mental health and that it's a very grave health concern in Canada. I also appreciate how you spoke frankly to say that even though we should take these matters very seriously, you believe personally that we are not yet ready. You're not giving the green light for expansion. And so this leads me to a question, just to step back a bit. The question is as follows. Whatever our capacity to respond to these requests may be, and whether or not there are rules and guidelines which can provide a way forward, my question is as follows. Do you believe that the Canadian population itself is ready for MAID in the case of mental illness?
Dr. Gagam?
Perhaps Dr. Gundam would like to answer.
Sure. I wonder, in this case, if we're putting, the cart before the horse here. When we look at any sort of illness, when you want to treat it, you have to look at the roots. That's what we're taught, the root cause. And if you really want to cure it, you have to look at the root cause. And you look at mental illness, it's not something that just arrives out of the sky. There's lots of deep, complex, intertwined causes for it. Working in addictions now for the last 7-8 years, I've yet to see somebody with severe substance use disorder that did not have some very difficult, traumatic childhood experiences, adverse childhood events, to varying degrees. And that impacts your ability to cope, your coping mechanisms, all that. So I think when we're talking about readiness, I think before our treatments, we are probably not even there.
Pardonnez-moi, Dr. Gagam, je veux pas savoir si les professionnels de la santé sont prêts.
I don't want to know if healthcare professionals are ready. My question is whether you believe that Canadians are ready for this kind of change.
It's hard for me to answer. I can't answer for the population if they're ready. It depends ready from what perspective. If the question is, would the majority feel this is appropriately ready in terms of that they're ready, this is the right thing to do in that sense, it would be hard to say. I don't want to speak for the majority. I have my own individual, but I think if they knew the full facts, I do not think they would be ready.
Rapidement, Dr. Serene.
And quickly too, Dr. Serene, do you have something to say?
Here from Canadian Mental Health Association, Canadian Association of Suicide Prevention, Inclusion Canada, all have said that MAID we're not ready for MAID for mental illness. They've said that publicly. So I think it's very, very important. It can be theoretically thought about, but in reality, to make it available in Canada, you can't differentiate MAID from suicide. So,
Dr. Prokopi, Ms. Prokopi and Dr. Young, very, very quickly, because I only have about 30 seconds for the both of you. Do you think your neighbors are ready? Do you think I have to go and sell this at the doors. Do you think that, the people who you meet every day and you talk to in a grocery store, do you think they're ready for this?
So I can't speak for my neighbor, of course, but I can tell you that the members that we heard from our hospitals feel very strongly that they have a duty of care in terms of being able to have guidelines that are consensus-based and know how to apply these things and know that people have equitable access to care and are able to get the mental health care that they need. And in the absence of all of those things, then people feel like they're not able to provide that service knowing that all of those gaps exist. And so I think that's important to consider. And I think, I think the Canadian public would want to know that the people that were providing that care felt secure in their ability to do so, and that there was the necessary infrastructure there in order for them to be able to do that.
Thank you, Dr. Young. Thank you. Madame de Bellefeuille, 5 minutes.
5 minutes for you, Madame de Bellefeuille. Thank you, Chair. So there's no consensus on expanding MAID for those with mental illness as the only factor, but we've also seen that in provinces across the country, there's insufficient support for mental health services, and this is a matter of sufficient federal transfers to provinces to provide these mental health services. But there are those who suffer from an incurable and persistent mental illness. Do they not have the freedom to choose? They do not have the liberty to choose, the freedom to choose, to live independently and with dignity. Is this this is what we look at for chronic illnesses. What I'm trying to say is that someone who has a mental illness also has this right if they have a persistent, incurable illness, if they have all the services, all the treatments that they require. Surely, do they not also have a right to make this decision, about themselves that is free and informed? In your practice, do you see people who suffer from a mental illness? And I understand why this person wants MAID, because there are no other solutions for this person to put an end to their suffering, and so far I would approve MAID in their case.
Thank you for your question. I think, again, as I've said in my statement, and the American Psychiatric Association position paper states, that in the moment, suicidal ideation or MAID request, a clinician cannot differentiate whether this person is part of their mental health or psychosocial issue. And you can have 100 treatments for years before, but that doesn't tell you what's going to happen in the future. And that is very, very important. And as others have stated, the majority of Canadians don't have access to appropriate
Excusez-moi,
evidence-based
docteur, je ne veux pas vous
psychotherapy.
interrompre. Ça, je le sais.
Sorry to cut you off, Doctor. Yes, we know that all citizens across Quebec and other provinces don't have an equal access to the same types of care, but someone who has a persistent and incurable mental illness, do they have the right to choose for themselves what they feel is right? It's as if there were kind of discrimination between two categories of people with illnesses. I agree with your opinion that there's no consensus, that it's not the right time to expand MAID to mental illnesses, but we have to prepare for this because there are those who endure these incurable and persistent mental illnesses, will request it, and we have to be able to relieve this suffering. And so my question for you, Dr. Gundam, what have you been doing to deepen your readiness, your knowledge, because there will be a time in the future where we have to make this decision. What are you doing on a clinical level to support these individuals who have a persistent and incurable mental disorder?
Thank you. I think what I've been doing, I think my position over the last 8-9 years working in addictions has changed. It's evolved. I was still a supporter of MAID, and I do it regularly. Now, I think the premise here we have to look at is we're talking about incurable. What are we basing that on? what is the standard definition we have for treatment resistance often used? Treatment resistant to what? Treatments have been offered. Is that enough? Were they culturally specific? Were they trauma informed? You have individuals that have all these issues, and they're not going to engage. There was Dr. Newfield a couple of days ago talked about therapeutic alliance. Just because something is offered, there's no connection. Is the person, where are they in their disease trajectory? You know, are they pre-contemplative, contemplative? Do they believe in it? All those factors are known. Research shows that treatment would work or not. Are we counting for all that? And then when you look at any treatment, actually to be treatment resistant, we talk about a biopsychosocial treatment for all psychiatric issues. Biological is medications. Okay, yes, we give medications, but are they actually following them? Are they compliant or adhering to them? The psychology, therapy, do people have funding to take therapy? Do they actually access it? If they're single parents, do they have the money for it? Do you have the time for it? And then the final part, social. That's usually a little footnote. And if you look at most of the psychiatric assessments, not because of the fault of everybody's intentional, but those are out of the grasp of the psychiatrist or the treating physician. And those, many cases, are the fundamental roots for many of these ailments. And we're saying they're treatment incurable, but we haven't given equal time, effort, resources to the biopsycho and social. So how can we say they're incurable?
Thank you, Dr. Gunham.
Senator Moody for your last 3 minutes.
Thank you, Mr. Chair. I'm sorry I can't get my camera on, but I will ask my question. And just to point out for Mr. Fergus, in 2023, Ipsos survey showed that support for MISUMC is 80%. My question is for Ms. Procopi.
Mr. Lott.
I don't believe it's permitted for members to intervene with their cameras off.
Yes, sorry, Senator Moody, you're required to have your camera on.
I'm trying my best. I keep clicking
could we
it.
maybe go on to the next senator, and we'll try to get IT to sort that out in the meantime?
Will I have the opportunity to ask my question? Yes, there it is.
There you are. So you can go ahead. Okay, 3 minutes from now.
Okay, thank you. So my question for Ms. Procopi is this. Are all the services deemed to be necessary or even essential for Canadians and for Ontarians available at all hospitals across Ontario? Is it not a fact that we went through in the past 20 years a process of regionalizing care so that certain hubs across the city have certain levels of care that are not available at every hospital, and selected services are not available at every hospital because of resource problems, because of critical mass issues, because of available expertise, and other reasons? Can you explain how this reality is not a problem for some of these essential services for Ontarians, but for mental health? You would not see care become available, and particular care around MAID become available because you perceive that all hospitals should have them equally.
I'll start by reiterating what I said earlier, which is a point that you alluded to, which is our concerns around broader access to mental health care across the province. We have seen the emergency department visits for mental health increase by 11% in the last 5 to 6 years. We track something in Ontario called alternate level of care patients. These are patients that are waiting to be discharged from hospital to go somewhere else, to go home, to go to long-term care.
Sorry, the question is about whether or not you see some sort of comparison between the fact that there are many services not available across every hospital that we still offer in Ontario. And we actually rationalize that care in certain places and don't offer it in every hospital. Is it a problem? Why is it such a big problem for us to not have MAID in every hospital to the same degree, to the same level? Why is that going to stand in the way of making this service available to Ontarians, to Canadians?
Well, if I understand your question, I would say that not every service is available in every hospital. We have regional programs in Ontario, like cancer. We have localized programs. So again,
and that's my point.
Depending on where you live in the province, depending on geography, depending on rurality, depending on the complement or composition of the physician and nurse practitioner groups, will determine the services that you receive. That is the case across any service, not just in the context of MAID.
So in the context of MAID, why is it necessary for you, or for us, before we proceed, to have equal levels of service and access across the system, for you to feel comfortable, or your group to feel comfortable that this is something we can only then proceed with?
Very, very briefly.
I would just say to the comments that the panel has made, if there are not access to mental health services, if there are not access to housing, to other community-based services, to the treatments that the doctors on the panel today have described, how do we know that the person's underlying mental illness is irremediable? We need to have those access to mental health services in place and consensus amongst clinicians before we're going to get to a point where I think medical assistance in dying for mental illness is going to be collectively accepted.
Okay,
But those are a lot of conditions.
Thank you. Senator Osler for 3 minutes.
Chair, and my question is for the Ontario Hospitals Association. It's a little bit in follow-up to the last question, and access to care. So as you know, access to care, healthcare administration and delivery is primarily a provincial responsibility. What actions has the OHA taken with the Ontario government to resolve these issues in order to be ready for the lifting of the mental illness exclusion?
Maybe I can speak quickly at a high level and then ask Dr. Young to speak to some specific examples. So part of the OHA's role as an association is to represent the voice of the hospitals of Ontario. And so we do that by working closely with the provincial government to not just expand access to hospital-based mental health services, but also to ensure that hospitals are working closely with primary care, community mental health, long-term care, home care, so that people can have access to the services they need in the location that they need. There are certainly significant gaps, as Dr. Young and I have both alluded to, is that we don't have access to care that's equitable across communities. And we also know that there are certain populations that face those inequities in a much greater way than others.
And I would just add to that to say that we find that a lot of people come to the emergency departments and come to hospital because they're not able to access care in the community, and yet this type of care is care that needs to be offered on a continuous basis over a longer period of time, and not having access in the community has been a big barrier. The Ontario Hospital Association, together with many hospitals across the province, have been very strong advocates of increasing home care and home care access for those with mental health, as well as trying to increase the access in the community to various types of treatment, including cognitive behavioral therapy, as well as RTMS and ECT. But we still, despite all of that, we've made gains, but we still fall sort of well behind what we think would be a reasonable amount of care that's available equitably across the province.
And thank you for that. Two quick follow-up questions. In 2016, when C-14 became law, was there consensus on MAID? Because you did talk about needing consensus. Second question, and in 2021, when MAID became legal for those whose natural death was not reasonably foreseeable, was there consensus?
So I would say I think there was certainly more consensus than there is now. We work closely with colleges, the government.
In 2016 or 2021?
In both.
Okay.
I think our objective is to create a framework to allow organizations to adapt in their specific circumstances. As I alluded to earlier, we have a number of our members that are faith-based organizations, and they've worked through their own challenges to encourage and promote access and patient choice. And so it hasn't always been easy, but certainly we've worked collectively as a group to try to make that accessible in ways that meet the needs of the patient, but also recognize some of the access and equity challenges that the sector is facing.
Thank you, Ms. Prokopi. Senator Wells for the last 3 minutes.
Thank you, Chair. Dr. Serene, you said that without an international standard, we cannot regulate extension of MAID for MI-SUMC. However, there are multiple jurisdictions that offer MAID in some form for persons with a mental illness. So, for example, in the Netherlands, they use the concept of due care as a base standard with the assurance that the person is competent and conscious. This is the same in Belgium and Luxembourg. Spain and Colombia have developed other standards. So my question is, why are these standards not considered acceptable for us in Canada to use as a guidance should this committee decide to extend MAID for MI-SUMC? And what have these jurisdictions, what do they have that Canada does not have?
Excellent question. Thank you for your question. I do think it's very important to remember that there's only very few countries that have allowed that. And if you look at the data very carefully and look at the legal framework in Netherlands, you still have to have gone through a number of treatments. So the provider can actually stop. And so that's one part that in Canadian legislation is not there. So in Canada, you can think about the options as far as treatment, but you don't have to go through them. And there have been significant concerns internationally about people dying in some of those countries. So again, internationally, the International Association of Suicide Prevention, the American Psychiatric Association, and the vast majority of countries in the world do not allow MAID for mental illness.
But the countries I mentioned do in some form. So do you not think that there are important lessons that we could learn here in Canada should we an extension be lifted to provide those safeguards and those regulatory processes in place? I'm saying we've got lessons to learn from, so why can't we apply some of those here in Canada?
But I think that's why in 2025, the American Psychiatric Association had a position paper on this issue, and the International Association of Suicide Research. So legally, Canada is one of the outliers as far as countries that allow MAID with that having to only consider treatment options rather than going through them. And that is a big difference that has already been an issue in Canada. But also, if you allow it for MAID for mental illness, it goes back to differentiating MAID from suicide and mental disorders. So again, consensus on this topic is not there, and the international guidelines really do not support it.
Well, thank you very much for these members of the panel. I know we kept you waiting for longer than expected, and we be sure that it is quite appreciated. I wish to thank our witnesses, the translation team, and all the staff that is assisting us tonight, and all of you for your collaboration. It's been, thanks to all the collaboration of all, we were able to make it despite some adjustments. Tomorrow night, we is not sitting in this room, but we're sitting on the floor below in room 025B here in the West Block. So make sure you come to the right place. I now declare this meeting adjourned.